There's a diverse array of different approaches to graft-versus-host disease prophylaxis, and these include other drugs that may impact on alloreactive T cell sort of functionality or survival in the early post-transplant period. Going back over a half century, methotrexate was really one of the first drugs that showed efficacy in decreasing graft-versus-host disease, and then that was then used in combination with a calcineurin inhibitor, initially cyclosporin or later tacrolimus. And those had a substantial impact on reducing severe forms of acute graft-versus-host disease, but ultimately did not make a big impact on preventing chronic graft-versus-host disease. And this has been a major effort within the field. Fortunately, post-transplantation cyclophosphamide does seem to reduce the risks and severity of chronic graft-versus-host disease, but there are alternative strategies to do that, such as T cell depletion, either in the graft itself ex vivo, so to deplete it in the graft and then infuse in the patient, or in the patient in vivo with medications like anti-Thymocyte globulin ATG or alemtuzumab or other things that will kill those T cells within the body and reduce both acute as well as chronic graft-versus-host disease. These three approaches really have had the biggest impact on reducing chronic graft-versus-host disease, although there are other medications that have been used to try to mitigate acute graft-versus-host disease. The one that's, I think, had the biggest impact recently is Abatacept, which is a co-stimulatory molecule blockade, which is able to reduce acute graft-versus-host disease, although it doesn't show an impact on chronic graft-versus-host disease. But other drugs like JAK inhibitors and others are also being tested for this purpose.